what's the rationale behind the combination of targeted therapies and immunotherapy?
I can take that. So, you know, I think the first rationale is if an oncologist has two drugs in front of them, they're going to want to mix them. But there
Both
is
have shown survival.
Correct. And so you say, well, if one works and the other works, I bet maybe if they together they work better. And I think, you know, there's obviously a caveat to that, which was demonstrated by the vemurafenib and ipilimumab combination. Was way too toxic. You know, patients couldn't tolerate it. A lot of grade 3, 4 hepatic toxicity. So, but the rationale I think is interesting because there's been several interesting studies showing that upon starting BRAF inhibitions, you know, biopsies show that T cells are actually coming back into the tumor where they weren't there before. And you know, why is that happening? Is the microenvironment now becoming less immune suppressive? I don't know, and does it happen for everybody? I don't know, but that does provide a rationale that, well, heck, if the T cells can come in with a BRAF inhibitor, it would be a nice time to add a checkpoint blockade inhibitor. It at least makes sense that way. We'll see if it actually can be safe, though.
And 1 is okay, 2 is better. What about 3? Dr. Kaufman.
Well, I think that's where we're headed. And, you know, certainly there are some nice animal models that have started doing triple immunotherapies. And there's some recent data published in a melanoma mouse model where if you add CTLA-4, PD-1, and PD-L1 blockade, you actually do see an additive effect with each additional agent. So, you know, at least the hint is there that we might see that. Not sure what the toxicity profile is going to be with these. So you know, but with some of the less toxic agents like TVEC, GM-CSF, it might be very possible to really be thinking about 3 or 4 combinations.
And interestingly, we have dermatologists on this panel, we have surgical oncologists, medical oncologists, but I'll speak for the radiation oncologists that radiation is getting a grander and grander role in the care of our patients through the abscopal effect, the ability to initiate a further anti-tumor response. And what I've seen in the clinic is possibly a greater response, but truly not an increase in toxicity. So
yeah, I would agree with that. I've seen that as well, and it's been reassuring. And you know, like you don't have to have just the abscopal. I know everyone, when we talk about radiation and immunotherapy, we talk about the abscopal, but you know, I've also seen, you know, for instance, a patient with a very large lung lesion and pleural effusion when he presented, and you know, we started him on IPI and radiation, both for palliative and systemic treatment, and I personally think he got a much better response than I would have expected him to have with either one of those agents alone.
So you allowed him to have the time to get all of the immunotherapy.
Correct.
I think that also brings us nicely to patients with brain metastases as well.
Oh, yes.
And we know that in patients with brain metastases, I think still the main treatment for that will be radiation, whether it's stereotactic radiation or whole brain radiation. We tend to use primarily stereotactic radiation. In those patients, we also often want to get the immunotherapy on board. So we do that in combination, that we give ipilimumab and brain radiation at the same time. And I think not, you know, hope to have an abscopal effect, but also I think that to sort of get the immunotherapy on board as well as early as we can.
So that, I think, is the last frontier for us as melanoma physicians. I think radiation alone, not enough. Possibly treatment alone, not enough. But the fact that we've shown that targeted therapy can work in the brain, the fact that we've shown that anti-CTLA-4 therapy can work in the brain, and significant responses with combinations outside, the next questions are going to be what happens when you combine these drugs, 2 or maybe 3, like Dr. Kaufman said, and the field is coming to that. Actually, the data with ipilimumab and nivolumab, how impressive it was has led to a brain mets trial that's currently ongoing, and hopefully will be presented soon. All right, but that's not the final frontier. We're not done yet. I think we've seen what these new targeted therapies and immunotherapies can do, and we've been fruitful in being able to take these drugs to the community where these drugs are available. But we still have